We want to make sure that our cancer patients are getting enough nutrition, the proper nutrition. They have that anorexia that comes with the cancer, but then also all the side effects of the medications that they're receiving, the radiation, the stress of it. Make sure that they're getting enough hydration because of that side effect of nausea and vomiting. And then also because some of those medications are nephrotoxic, we really want to monitor that INO. We want to make sure they're urinating enough and that their creatinine stays at a good level, right? So know your normal ranges for that. We talked about the side effects of medications and how we should manage those. We need to offer psychosocial support. We need to involve the family. That's a big part of this treatment. And realize that a lot of the time they're going to go through a grieving process. So remember your 5 stages of grieving. So, we have that denial is a huge factor here. And remember, if somebody is in denial, it's not our job to argue with them. We just need to be supportive. They may also feel all of the other stages of grieving, and the family's going to go through those stages of grieving too. So you should expect that and not be surprised, if they're angry one day, depressed another day, in denial, bargaining with God. Our job is just to be supportive. And then cancer pain is a big factor here. It can be very painful. So we're not so concerned with addiction right now while they're in treatment. So you may see that they get some pretty heavy duty medications, a lot of narcotics to deal with some of that pain. But also realize that we don't only treat pain with medication, right? So think about the other things that you can do that, like for acupuncture, for example, or meditation, distraction. Remember all of the different ways that we can treat pain, not just medication, always. Some other complications of cancer, they may have paraneoplastic syndrome. So that's just like the immune system going into hyperdrive, trying to react to the cancer itself. So you may see an extreme immune response. Tumor lysis syndrome is when some of those cancerous cells start to die and lyse. Then we may see very high potassium levels, high uric acid levels, high phosphate levels. So we need to be monitoring their cardiac system. So we're looking at telemetry, making sure that we're not seeing a lot of PVCs or arrhythmias. They can go into a deadly rhythm, if their potassium is too high. So we're also looking at their renal function because that can cause renal failure, right? And they may go into seizures, and it can eventually cause death if it's serious enough. If they're getting a bone marrow transplant, they may have graft versus host, where the body's rejecting it. So we need to look for those symptoms. That can be pain, nausea, vomiting. They could have an unexplained rash. Unfortunately, a lot of those symptoms are the same types of symptoms that you might see with chemotherapy, so it's easy to miss. So just be vigilant. And then I think we talked about fistulas on here already, where that's an artificial pathway between two incompatible organs like the bladder and the bowel, or the bladder and the vagina, bowel and vagina, those organs that are close together, they kind of form their own pathways. So that's a huge infection risk, right? And it can also be really uncomfortable, painful. So now we're going to talk about some specific types of cancers, just the most common ones. You can have so many different types of cancer, but these are the big ones that you see, at least in our country. So breast cancer is fairly common, especially in females. It can occur in males also. But I had one oncologist tell me that if every female lives long enough, they will eventually get breast cancer. And if every male lives long enough, eventually they'll get prostate cancer, just because of the way your hormones change as you age. So that's your number one risk factor, is your age, right? The risk increases with age. And gender is much more common in females. There is a genetic factor, so if you have a close family member that has a history of breast cancer, then you probably need to be monitored a little bit more closely. If you have a personal history of breast cancer, the risk of it coming back is really high. Any previous chest irradiation, if for some reason somebody had to have a lot of chest x-rays, so think about people like who have COPD, or CHF maybe, or things like cystic fibrosis. If they've had a lot of irradiation to the chest, that increases their risk. And then we're also looking at menstrual history, so if their first period was before the age of 12, or they went into menopause after the age of 55, that will increase their risk of developing breast cancer. So some of the clinical manifestations that you might see is that non-tender lump or mass. So it usually starts out pretty small, like a pea size. It's very firm. It's usually not painful, and it doesn't move around easily like the way that a cyst would. You can move a cyst around under the skin, but a tumor is anchored, so it doesn't move around very easily. Most of the time they will be in the upper outer quad, so close to the armpit. Also, you may notice abnormal nipple discharge, nipple retraction, dimpling of the skin, which sometimes is called like orange skin, a change in the location of the nipple, or a rash. So we need to make sure that women and men really, are doing self-breast exams pretty frequently, at least every month. And it needs to be done by a professional at least every year. So there's a link on here. If you go to the PowerPoint on D2L, you'll be able to get to it too, explaining how a self-breast exam should be done. And this is something that you need to know so that you can educate your patients on how to do it correctly. So make sure that you check that out. So detection is usually through that self-breast exam, or maybe it's through a clinician exam, that yearly clinician exam. Then we would do a mammography, and if they find there's a pretty dense area of tissue, they may do a biopsy to see if it's cancerous. So mastectomy is usually the treatment of choice. We just need to remove that cancerous area. They may do just a lumpectomy if it's pretty small and they think they can catch all the borders. Somebody may get a breast reconstructive surgery afterwards if they've had a breast removal, that mastectomy done. Then they may do that hormone therapy and that chemotherapy and radiation to the site. So lung cancer is also fairly common. So the number one risk factor for lung cancer is smoking, which you probably already knew. But it can also be exposure to ionizing radiation or an inhaled irritants. So that can be dependent on somebody's occupation. Maybe radon exposure, and of course the risk increases with age. Some of the clinical manifestations you may see is that dry, nagging cough that's unexplained. You may see hemoptysis, which is coughing up blood, wheezing, shortness of breath, chest pain, hoarseness, dysphagia, and then this clubbing of the fingers and toes, so the digits become rounded at the end. Unfortunately, a lot of these symptoms are also symptoms of COPD, and a lot of times our smokers end up having COPD, so we may miss the signs of cancer until it's fairly late in the game. So this is diagnosed through chest x-ray. We may also do a sputum sample and look at it under a microscope, right? We may do a bronchoscopy and get a bronchial washing, chest x-ray, CT of the chest. We may do blood tests, specifically CBCs, LFTs, Chem7s, which is looking at their chemistries, like their potassium, sodium, and all of that. And that's to see if they have paraneoplastic syndrome. We also may try to rule out tuberculosis, because on a chest x-ray, you may not be able to distinguish tuberculosis from cancer, because tuberculosis looks like a nodule on a chest x-ray. They may do a pulmonary function test and an arterial blood gas too. Treatments for this may include resection, which is surgical, right? Lobectomy, where we're removing a lobe, or a pneumonectomy, where we're actually removing an entire lung. We may also do chemotherapy and radiation. They may get bronchodilators just to maximize, whatever we have there, and analgesics just because cancer is painful. We have to treat the pain as well. Skin cancer, like I said, is the most common type of cancer in our country, and it may seem, pretty not as serious as some of the other cancers, but it can become very serious because oftentimes it's not detected. So we really need to be doing a thorough skin check on people when we're doing an assessment, especially if they're very freckly or pale or redheaded. Those people are going to be at an increased risk of developing skin cancer. Heredity, if you have a family history of skin cancer, just also where you're from, your genetics. If you're from your family history is from Sweden or some northern country where there's not a lot of sun exposure, then you don't have that melanin in your skin to combat that sun exposure. Some medications can put you at increased risk for burning, so those would put you at a bigger risk. If you've been through a lot of sun exposure, had a lot of previous sunburns, that's going to increase your risk. That's damage to your skin. Your risk increases with age. Xeroderma pigmentosus is a terrible disease that some people have where they are allergic to UV light, and that easily burns them. They pretty much have to stay out of the sun all the time, and that small amount of exposure that they have will increase their risk of cancer. And then if you've had any history of cancer, your risk of developing skin cancer is going to be greater. So this is an easy way to remember your assessment for this, the ABCDE rule. So A is for asymmetry, so we're looking at a mole or freckle. We want clean borders, so if you were to cut that in half, it would look the same on both sides. If not, then we need to do further investigation. So the border should be rounded, right? It shouldn't be irregular. The color should be pretty uniform. We don't want a lot of different shades of brown. D is for diameter. So if it's greater than 6 millimeters, that becomes concerning, and that's about the size of a pencil eraser. E is for evolving. So is it changing? Is it scabbing over a lot? Is it getting bigger? If so, then we need to check it out a little bit further. So diagnosis of skin cancer would come through a biopsy, so they may remove that suspicious area. They may actually try to get the entire thing out, so some of those can be pretty deep, so we may have to remove a pretty large chunk of someone's skin and flesh in order to get that out. You may also do blood tests, so again that would be like a CBC or Chem7, again to check for paraneoplastic syndrome. We may do a CT of the liver and brain just to look for metastasis, or an MRI of the brain. We may do chest x-ray and bone scans just again to check for metastasis. So again, that's surgery to remove the area. If it's melanoma, we have to get a pretty big chunk to make sure that we've caught all the borders of that cancer, because if we leave a few cells behind, it's just going to regenerate and then it can become metastatic. We may do radiation to that area. Chemotherapy, sometimes that chemotherapy may be a topical cream just to the one area to kill that cancer. Immunotherapy and laser surgery.